And I would like to welcome and thank each of you for taking time out of your day to join us for today's session, Why the JENVIS Pro is Worth It. Allow me to welcome also our very special guest, Dr. Jennifer Rayner, all the way from Adelaide, Australia. She's the director and optometrist at Aleve Clinic. Jennifer, it's an absolute pleasure to have you here, and we're really looking forward and are excited to listen and learn from you. Jennifer is a dry eye specialist and has been working in this specialty field for many years and also been working with the keratograph. So before we get to your session, just a few technical things. If you have sound issue, you will see at the bottom of your screen, there's a 3 dots, and you can go onto those dots and click on there, and usually you can set your microphone settings over there. Also for questions, I have Kai, the product manager of the keratograph, also on the line. So he's here to help you if you've got technical questions or any questions on the keratograph, the JENVIS Pro, also to Jen. Please write it in the Q&A and we will address it at the end of the session. So with that, Jen, I'm handing over to you. You can share your slides and we are excited to learn and listen.
Fabulous. I'll just share those first. Here, she says, there they are. Fabulous. Excellent. Thank you so much for having me. Thank you, Tresia, for moderating, and Kai for being on board for all the technical stuff, because that's you, not me. Thank you very much to Oculus for having me as well, because I have been using the keratograph and you know, the JENVIS software for a while now, and it is great to share my experience with, especially in dry eye, which is definitely my passion. And also thank you to Design Vision here in Australia, who are the distributors for the Oculus products, and you know, they've been so supportive with bringing dry eye, you know, management, I guess, to the forefront, and being really supportive of me and my practice. So thank you all for having me. The rest of my colleagues joining, my ophthalmology colleagues, you get to listen to my passion for 45 minutes about dry eye and why it's so fabulous, and having software to manage it. So, of course, my name's Dr. Jennifer Rayner. I'm an optometrist, as Tresia said, in South Australia. My business partner and I opened the clinic in 2016. Before that, I'd been practicing dry eye, of course, but our clinic was the first in South Australia to be a standalone dry eye clinic. So we don't do any refracting, we don't do any dispensing. We don't, as I say to my patients, I don't look behind the back of the cornea. I only care really what's on the front. As I said, I've also used the JENVIS Classic, of course, for probably about 7 years now, and I honestly do think it's pretty much the best software out there for dry eye. It's very easy to use, and we'll go through sort of, you know, how I use it, just a small case study of how to interpret, and you know, why I am loving the JENVIS Pro, of course, as well. I will do a little bit of a disclaimer. I am now a key opinion leader for Oculus, Oculus Asia since December, but as I said, I've been using this product for quite some time. So this is a little picture of our practice. Reception over here, of course, my clinic room through into there. Over to the left is our treatment room, and that's where we do all our testing and we IPL, etc. So it's a small practice at the moment. Dry eye has been, of course, you know, an area that's been ignored for a long time, and it is certainly a growth area. So, you know, within the next couple of years or so, we'll be extending to a bigger practice just because the need's going to be there. So I guess one of the things where, you know, why are we even talking about dry eye? Our patients come in, you're getting this all the time, we all do. Your patients are coming in, they're saying, why can't you treat my dry eye? I'm doing what you tell me, I'm doing the heat, I'm using my artificial tears, maybe using steroids. It's getting worse, or nothing seems to be changing. And I guess traditionally, dry eye has been very time consuming and very complex to treat, and it still is. It's certainly a lot of understanding to it. There was little research, or the research that was there not applicable. And that's, of course, changed quite dramatically. One of the things, of course, we're doing is starting to recognise that, you know, it's not just the tear film, it's what's happening on the ocular surface and all the influences that we have that cause dry eye. So our lifestyle, the environment, you know, systemic things like autoimmune disease and the medications we're taking. So as our understanding of the disease increases, and more importantly, the patient awareness increases, we're going to have to diagnose dry eye. You're going to have to look for it, and you're going to have to treat it or refer it on to somebody who will, because the patients are going to be demanding on it. The internet is a very, very powerful tool, as we know, and patients are finding information, but they need that clinical, you know, approach, that professional opinion onto what to do with their dry eye. So, you know, if you've got the software to help you diagnose it and get some management started, it's going to put you ahead, particularly of, yes, perhaps some of your colleagues. I think the main thing is understanding that the meibomian glands are the biggest part of our tear film anomaly at the moment. It's not, of course, the aqueous like we used to think. It really is meibomian gland function, that meibum consistency that's causing, we say, you know, say 85% of evaporative dry eye, but in my practice, I would say the meibomian glands are probably involved in 95% of pain. So it's really critical that we're looking at the ocular surface and we're looking at meibomian gland function and treating that, of course, as well. So again, the software that you have, as opposed to just looking at the slit lamp, putting some fluorescein staining in or some lissamine green staining in and going, okay, you know, here's your blink rate, there's your tear evaporation rate. When you start getting more information, utilising software, you can understand your prognosis a lot more, so your patient's expectations, managing their symptoms, you know, how much management do you need to be putting into, and also understanding, we all love this, when the signs and the symptoms just don't equate. And we get that all the time. A patient will come in and they're in so much discomfort and they've been in discomfort for a long time and affecting their lifestyle, affecting their work. You look at the tear film and it looks fine. So good software can help you sort of nut out what's going on. But I truly believe that all practices who are treating dry eye, whether you're entry level or whether you're more advanced in a dry eye clinic, should be having dry eye software, of course. So what's the advantages of the JENVIS Classic? And I'll talk a little bit about the JENVIS Classic first, and then I'll explain a bit more about the JENVIS Pro, and I'll give you a case study, just a short case study about sort of how I interpret, but all the advantages of having it. But the first thing is, why would you even have, I guess, the JENVIS Classic? And again, I'm kind of assuming that I've got participants on here who may be interested in getting the JENVIS product, may not have it at all, or have the Classic and looking to upgrade to the Pro, or have the Pro and sort of see what tips I have. So some of this may or may not be pertinent to some of the participants. So first of all, the JENVIS Classic is a great entry level. So it's of course a little bit less expensive than JENVIS Pro. It's very easy to get really good familiarity with the software and its capabilities. So it's a great way to sort of feel like, you know, what are you testing? What are the parameters? How do you interpret that? What do you do with all that information? It, of course, gives us a lot of quantitative measurements, so the tear meniscus height, for example, NICBA, and qualitative data, so, you know, questionnaires and stuff. So what that does is help us with education with patients. It helps us with future comparisons. So when you want to see if your treatment options are working or your management is working, you know, repeat the test, all the tests, some of the tests in 3 months' time or so, see if there's change. And also, if you're interested in doing research, it might be in-rooms research, or you might be part of a broader network of research, you've got those things that we use in research. So, you know, questionnaires, non-invasive breakup time, all those objective measurements that we need. And that's part of your JENVIS Classic. It is very easy for your technicians to use. Now, I say yours. We started the practice, again, dry eye, it was 5.5 years ago. No one was really talking about dry eye, certainly here in Australia, a little bit, but not much. So building the practice up meant that I was doing a lot of the testing, and I really would encourage you as clinicians to start off doing, even if you're just doing it for, you know, a week or so, because there's some subtleties when you're testing that you pick up that you don't necessarily recognise if you've never done the testing before. So it may be that you're incorporating the software yourself, you're doing the testing yourself, or like myself, we'd have a technician who does all my dry eye workups and stuff for me. So that kind of leads us over to, you can have the software for the OCULUS keratograph in your room, so it can be with your slip mat, or you can have it virtually like we do, and in another room we just pull it up virtually and go through with the patient in the clinic room. The education capabilities of the JENVIS Classic is absolutely amazing. When we're talking to patients, we talk about MG dropout, gland dropout. We talk about, the tear film evaporating and tear breakup time, and they don't really understand what we're talking about. It's not until you can actually show them, this is your oil glands, you see how you've lost most of them versus this is normal healthy oil glands, that the penny suddenly drops. When they see their really unstable tear film versus a nice stable tear film, again, the penny drops as to why they're having problems and why they need to treat it and why this takes time as well. So it's a fabulous education tool. The report, we do give reports to patients, so they get this tangible asset, if you like, for their investment. So I don't know what the rest of the world is doing, but certainly here in Australia, our testing for things like OCTs, unless the practice absorbs it, but our testing for things like mybography, OCTs, that sort of thing, is an out-of-pocket expense. It's not covered by our national health system, Medicare, and it's not covered by private health insurance at the moment either. So patients are paying out of pocket, and in dry eye, they're very happy most of the time to do this because they want answers. But if they can see the value, not just here you go, this is why you have dry eye, but they've got a physical report that they can refer to and they compare their future results to, it again just gives that sort of bang for the buck. I think that having software when you've got a special interest in an area, like myopia management or dry eye management, as the case may be here, I think that can be a real USP for you as a clinician, that unique selling point that sets you apart from your colleagues. If a patient comes in and you can give them this valuable information, they can see what's happening, that gives you, again, a point of difference. So I think as a practice builder, it's fabulous. And of course, it is profitable for the practice. We're making an investment and we need to obviously see a return on that. So again, the value that we get just helps build the practice. The other thing is, and I'm not going to talk very much, no, I'm not going to talk at all about contact lenses on here, but this software, the JENVIS software, it also does topography, it does pupillometry, contact lens fitting. So it's not just for dry eye, and remember that, because you can utilise this in your general practice as well and all your contact lens patients. So I'll go on a little bit about why the JENVIS Classic is so good, and then I'll explain about the JENVIS Pro. So what we can do, there's a few different functionalities in here. So we've got our individual tests we can do if we like, and that will include things like tear meniscus height, your non-invasive breakup time, which is really important to be able to compare to your tear breakup time. And when I said before, you can pick up the subtleties as well in your testing, and sometimes your nick butt doesn't match with your tear breakup time, your fluorescein breakup time. And there's a reason. As you put a whole heap of tests together, you can actually work out what's happening. You might have reflex tearing, for example, on the nick butt, so it looks like you've got this really stable tear film. But when you look at the fluorescein breakup time, it's barely breakup all over the place. So suddenly you go, and then you look at your meniscus height, and suddenly you go, there's reflex tearing. So that's why the nick butt's picking up a different, perhaps, testing result than what the tear breakup time. So I love having both of those. Your lipid layer, which of course, the colour represents the amount of lipid that's present. Your tear film dynamic can be taken, so that quality of your tears, whether it's moving fast, whether it's a little bit sluggish, so sort of kind of what is in that tear film. And again, all these subtle things, when you start looking into those patients who have the signs, symptoms, but no signs, they do have signs. You've just got to look for them. This is where we can actually start delving in a bit deeper and starts making a lot more sense. Your eye redness, so your bulbar and lingual redness, which again has another little advantage on it, not only grading your redness, of course, you know, not everyone has red eyes with dry eye, but a lot of people do. But it also gives you a bonus picture of your lashes. So if there's really heavy blepharitis that you're just not looking at particularly at the time, it'll pick that up. Sometimes it'll pick up that lid margin redness along there, and your telangiectasia. But also it's a great reference point. If somebody comes in 2 years, 3 years later again, and they've got a nevus or they've got a lesion, you've got a picture as a reference point to go back and go, it wasn't there, or it was, is it old or new? So that's just another bonus without having to take a separate picture. Imaging, meibography, infrared imaging is the cornerstone of your practice. I use this analogy with patients like having a broken bone. I can try and fix your bone, but without an X-ray, I don't know exactly how bad the break is, whether there's several fractures, and therefore what your prognosis is. So having imaging to me is just absolutely vital. You can, of course, visualize particularly inferior meibomian glands, but they are sometimes difficult on the slit lamp. But having a picture, literally worth 1,000 words. When a patient sees this and they can see that they've got some dropouts, so you can sort of see on here, you know, those oil glands are pretty good, they're pretty full, they are a little short, but over here they're not as full, of course, and you've got some dropouts. So when a patient sees that and understands, that's kind of why we need to be doing some ongoing management, ongoing treatment, why this is a chronic condition. That's incredibly valuable. And it's valuable because it makes people compliant. In my practice, and I'm only talking from my personal experience, most of my patients are either completely compliant or relatively compliant, or they completely, unlike contact lens patients, they'll completely admit that they're not compliant at all. So all of this information helps us manage them and then manage themselves. So having the meibography is absolutely vital, I feel, to dry eye management, because so much of our evaporative dry eye is, of course, about the meibomian glands. The tear film stability, so again on the JENVIS Classic, and of course the Pro, but the JENVIS Classic, you can take a video of your tear film with your fluorescein in there. You can again show the patient, you know, this is what normal healthy tears look like, it should be covering. Look at all this breakup, and they're absolutely amazed, you know, about what we're seeing, and that we're seeing what they're feeling, and that's really valuable too. We can see their blink frequency, obviously, their blink quality. Are they doing incomplete blinks, those partial blinks that, you know, very commonly associated with screen-based use? They can then see that they're not blinking properly, and they'll often admit that they know they don't blink properly as well. And so things like blink training, which is again very valuable and very useful, they'll do it because they can see that they're not blinking properly. And even just confirming things like your tear meniscus height down here, that's a low tear meniscus height. And of course your questionnaires, whether you have the McMonnies or the OSDI questionnaire is incorporated in that. So as I said, you can either do separate testing, or what we do is our dry eye report over here. Now, with the dry eye report, it gives you can bring up whichever pictures, of course, you want to be bringing up. It gives you all your testing regime that you want to be doing. It does do some grading. So as we go through, you can compare. So we go down to the little 3 dots down there, say on the nick butt, and we can compare all the nick butts that have been done previously. The other way you can compare is you go out to the display, and I'm sorry I don't have a picture of this, but you can go onto your display and you can compare 2 or you can compare 4. And that's where you can either compare these previous ones or you can do rights and lefts. So it does give you a display and a comparison. You can get those grading scales. So in all these parameters, again, there are those standardized grading scales to give you that, you know, quantitative measurement, if you like, and also give you that comparison, the baseline and the comparison. And as it's doing that, it will actually locate it on this colour graph as well. It's just a nice visual colour graph, probably more so for the patients than for us, but it just gives this nice overview of what the results are, particularly for the patient. When we're coming over to the customisation, now, again, I may be incorrect with this, but my understanding, certainly what I've done with the Classic, is you can only maybe do one report, I think, customized report. And certainly that's what I tend to rely on. I have relied on for the last 7 odd years, is my customization. So you can go in and you can make this however you want to make it for your practice. You know, what I do in my practice isn't going to be what you do. You may want more or less information. But you can go through and add in things like your osmolarity assessment. Of course, we use the tear lab, but whatever osmolarity device you're using, you can use add in things like the Sherma test. So that could be part of your report that you're doing. So a lot of fabulous information that's on there. What are the disadvantages? Because we're talking about, you know, the JENVIS Pro versus the JENVIS Classic. So I do find it's a little clunky. It's not quite as streamlined as I'd like. Again, if we go back over here to go into, say, compare the neck butt, I've got to click on there, and then I've got to choose the image, or I've got to go into the display. So there's a bit of back and forthing with it. When we're talking about the testing, again, the same thing. When we're on the right-hand side, we open up the exam, we take a picture, then we want to do the left side, so we've got to go back out, we've got to come back into here. So to me, it's a little bit clunky. Therefore, it makes it not as fast to be able to assess it. So if you're sitting with a patient and you're going through, it's a little bit more back and forth. And that education, of course, gets a bit static. You can't compare all your results simultaneously. So if you wanted to look at your neck butt results and your fluorescein staining or your tear breakup time, you can't do that at the same time. And you can't show the patients those comparative images. So for example, this is what your normal oil glands look like, normal oil glands, and this is what yours look like, unless you have a separate picture. So it's absolutely fine. A little bit clunky. And the same thing with the grading scales, as I said. The grading scales are written, but they're not a visual. So you have to have a physical reference point. So, you know, a few sort of course, pros and cons. So what is the difference between the JENVIS Pro? Now, first of all, you can see the difference between this one and this one. So that's our classic report. That's what we get with a JENVIS Pro. So what I'm talking about is the same sort of program as what I was just doing. I call it our meibomian gland dysfunction workup, MGD workup. And I like these particular parameters: the tear meniscus height, neck butt, redness scan, the meibography, of course, upper and lower, conj staining, blink video, and a questionnaire. That's my go-to. So all of a sudden, when I've seen a patient and we've gone through all the testing, this is the results that we get. And everything we want to do is all from this essentially home screen. So we've suddenly got this comparative over here. So when I was talking about the neck butt and the tear breakup time, you can see on this patient here, this looks fairly stable. The neck butt looks pretty good. So does the fluorescein staining. But over here on the left eye, you can sort of see there's some breakup, and that corresponds to the breakup right along there. So in this case, the neck butt and the tear breakup time correspond beautifully, but I can see that. I don't have to search through anything. It's right there. Those meibomian glands are there, so straight up I can look and go, okay, meibomian glands not too bad. Interesting, they're about the same, but we don't have a whole heap of dropout or anything that might indicate what the change is on the tear breakup time. So as a practitioner, I can just look straight up and go, right, that makes complete sense. On everything, on all our testing is grading scales, and they're there to obviously put as part of the assessment for the patient, but also for us. So when we're clicking on each one of these sort of headings and subheadings, your grading scales will be here. So if we get back to talking about the your technician, if you're having a technician doing it, it's right in front of them, the grading scale. They don't have to do anything. They just have to look and see which, where does it fit, the parameters. With some of them, things like the tear meniscus height, as soon as you grade them, the neck butt, that'll automatically default into here. So as soon as you grade things, it'll just click down into here, into your assessment over here. But this is absolutely fabulous. And you're doing everything just, like I said, from this one home screen. You can maybe look at one of those parameters. You might want to look at the redness scan. You might want to do just the right eye, and that would click up on here, or you can do everything. So straight up, that wow factor for the patient, the immediate accessibility as a practitioner to go, this is what I want to look at. And I have kind of a couple of different ways. Sometimes I'll go through certain parameters with the patient in the rooms, and then I'll go back through afterwards and have more, detailed look. So it gives you that ability to say, I want to do that. But the efficiency is absolutely fabulous. So I wanted to just sort of give you a bit of a case study on how I kind of interpret the JENVIS Pro. We got just recently, not long ago, we had a 29-year-old male who came in with a 1-2 year history of burning sensation towards the end of the day and occasional grittiness in both his eyes. He's a medical professional, but he's very screen-based. Interestingly, he doesn't find that computers exacerbates his symptoms, but wind and air conditioning does certainly. And so a bit of an issue at work with the air conditioning. Contact lens wearer, disposable daily, just intermittently for the last 18 months, completely unable to wear contacts anymore at all for the last month because of the discomfort. No medical history or medications, except he gets, some mild seasonal allergy. He's on oral antihistamines intermittently for that. He's tried the warm compress, 5-10 minutes and regular artificial tears and no relief at all. So quick examination, I'm not going through all his details, but essentially his vision's good corrected, 6/20/20, but his meibomian glands are quite inspissated with no expression when we're doing an assessment. So, not a lot there. So pop him onto the JENVIS Pro. Very easy to do when you go into your examination. You can go into your dry eye report. You can stay in your classic if you like, or you do your individual. But of course, I want to go into our MG workup. This is our default. And then when we follow up in 2 months, 3 months time, we'll do a follow-up MGD there as well. To start the program, so what will you go to when you're doing your testing? And of course, it goes through the capture program first, and then it will go into your assessment. So on your capture, it's very intuitive. So remember, I'll move this over here. Remember I was saying that on the Classic, you do have to go in and out, in and out. The Pro, you're right here. So it'll give you, it'll do your testing, and it's, again, quite intuitive. Depending on what you set up here on the right-hand side, those parameters that you want to be testing, those tests you want to do, it will do either the right eye or the left eye in whatever order is the most efficient for the program and for the patient. So we're, by convention in optometry and ophthalmology, we use our right eye first, and then we always test our left eye. It does get your head around this, but the camera will do it, so it's not back and forth, back and forth. It'll do it in a systematic way, so you're not wasting time on the patient as well, but it's really efficient. So you can see over here, the camera wants to do the right eye first. Testing wants to do the right eye first, but the camera's on the left-hand side. And so it's just telling me to move it to the right-hand side. So again, when you're getting used to using this, or you've got a technician, they've got those cues and those prompts to help them along, which we don't have in the Classic. The tear meniscus height is the first thing we're going to be testing on here. And this is not the patient, this is the prompt. So it's a visual, oh, that's right, I'm doing the tear meniscus height. This is what I'm going to be actually looking for and doing. That's right, I have to do this or I have to do that. As we know, the neck butt, those of you who do the neck butt on the Classic, the neck butt, you can't sort of override. It has to be captured, and then it does its thing. But it's quite confusing from a technician point of view. Should I be taking a picture? Am I taking a video? Am I letting it capture itself? So this prompt just helps them perfectly. And then you just click down here to go to the next one. So I'm not going to go through the testing. I'm going to go more through that, the assessment, what I'm going to get, that value. So let's assume that I've gone through all the tests on here with the patient, and we're going into the that testing aspect of it. So again, I'll come back to beginning at the tear meniscus height. So there's my sort of home screen, if you like. I've got all my images over here, and again I can do all of them or just those tear meniscus heights. And to measure it, you've got two ways. You can either just measure it on this screen. So you just you hover over here, it has measure, and you can just basically click and measure from there. Now that's very, very small, so it's not necessarily what you're going to be doing. At the end, I'll talk to you a little bit more about a screening program, and that might be really useful to do it then. But most of the time, we want to just go into our larger picture, so we've got more accuracy when we're measuring the tear meniscus height. So you simply hover over here, you right-click, It goes open exam. So again, very, very, very easy. And there's your bigger screen, and you can do your measuring tool from there. Then you simply escape from the program, go back into the home screen, go through all the rest of them. So same thing with the neck butt. So, just going back, that's what I was going to tell you. The grading is, so as soon as you put that in, you go back, the grading will be in there in that assessment tool. The grading that the software defaults to is an average grading. You can change that. If you want to go, look, the average grading is 20, but I actually want to go that medial aspect is 0.18. You can change it from a normal to it's a lower ear meniscus height in there as well. So you can customize this in many, many ways. The same with the neck butt. The software will default in your grading system to the average. I personally, and this is just the way I practice, I personally like to do the breakup at the first initial breakup time. So on this right side, the breakup time for the initial breakup and the average is about the same, so about 11.98, 12 seconds. A little bit of aberration there. I don't know what was going on with that one. But on the left one, the average is nearly 9 seconds, but the initial was 3 seconds. And so again, I'm comparing to my fluorescein staining time. So when I go back to the assessment, and I'll just sort of show you what I'm talking about there. I know this is pure meniscus height, but let's pretend it's the neck butt. I can change it from normal to slightly reduced if I want. So you just click on there. You can do left and right. And again, very, very easy. You've suddenly got all this information that you can collate literally at the click of a mouse. So the neck butt, again, okay in the right, a little bit low in the left, of course. Same thing with your redness. Now, this is where it starts getting a bit more exciting for the JENVIS Pro. Aren't you all excited? I am. I could talk about dry eye for hours, but I'll promise only another maybe half hour. So what you can then do is go to your grading system scales. Remember I said before, the JENVIS Classic has scales but nothing visual. So you simply open your exam like we did with the tear meniscus height, and bang, here is all your redness grading scales. So what it will do is it will have the patient's eye up here. You can drag it along, you can leave it there, whatever's easiest. You drag it along to meet whatever you think is that grading scale. Down here, the second half of the screen, you just click on whichever grading scale it is, and that will go into that assessment tool back on that home page. But it'll also give you tips. So on here, it tells you what the cause of the bulbar redness is, what your normal is. So again, thinking about your technicians who don't know, it'll tell you what the normal and what not normal is, and any advice for it as well. And then you just simply, without even leaving this page, you click onto the limbal redness, and bang, there is the limbal redness, the same thing. So you drag it along, find what you think is the likely grading, click it, and then go back to your screen. And just again, this is not just about dry eye. Remember that this is grading limbal redness. There's lots of reasons for that. So if you've got a patient who's come in with, say, iritis and got some ciliary body or body flush or anything, you can just take a picture of this and you've got that comparison as well. So don't forget, this can be used in general practice. So again, there's your visual grading scales, which the Classic just doesn't have. The same thing with meibomian glands. Remember, this is the pivotal part of, I think, of treating dry eye, is those meibomian glands. So once again, you open your screen. There's your grading scales. Up the top, down the bottom is your grading scales over here, and you just simply click from one to the other. Again, if you want, you can drag it along. So we're thinking this gentleman had grade 2 up the top, grade 3 down the bottom. And when we came back to our assessment tool down there it is. Don't even have to do anything. So you can sort of see that value in there. The same thing, of course, with your blinking. You can go all through all these parameters. And I just kind of want to, I guess, hopefully show you all the things you can use. You don't have to use. But the more you use this program, the more you'll see all the different functionality that will just give you so much more information and help you with your diagnosis and management. So we can again open our grading scales when we're looking at the staining, the conjunctival staining. We have everything up here that you can be comparing to. So as I said, you don't need a reference point, a separate reference point anymore. It's all on here. and just again going through showing you all the way you do your grading scales. And literally, like I said, this is just a click of a button. So just comparing him again, or kind of summarise this gentleman, his right one was quite stable. I sort of showed before, his right tear breakup was quite stable. His left was breaking up a little inferiorly at about 4 or 5 seconds. So what this will also do, once we've gone through all the testing on the right hand side here, we've done all our grading, we can add in recommendations, and those recommendations can be standardized or they can be customized. And again, you just click through each one. We also do Schirmer. Now, in that particular MGD workup, I don't include Schirmer because it's not part of that particular program. So I did it separately, of course, on this, just because of being a case study, and it just supported that he had a low tear meniscus height, sort of 10 and 8 or so in the right and left, so a little bit lower than normal. So no wonder he's got that low tear meniscus. So again, we do our testing. We've got all our grading systems in there. We've got our collective view, and putting this together now, looking at that testing. So his tear meniscus height is low. We've sort of established that. His Schirmer is low, of course, as well. Redness, not so much of an issue, but his tear breakup time equates to his nick butt time. So it all looks about right. What doesn't make sense for him is, why is his left worse than his right? And the only variable really, because his meibomian glands look about the same, is maybe that it's just a little bit lower aqueous production in his left eye than his right eye. Don't know. We all know that we get those anomalies. The right doesn't equal the left at all. But you can certainly see that you can get a very quick assessment from all those tests. And those tests take 4 or 5 minutes. Probably a whole test takes 10 minutes because we did the Schirmer, of course, as well. So easily come up with a diagnosis for him. He's got evaporative dry eye, likely with an aqueous deficient. Is it due to his antihistamines? I don't think so. He's only a seasonal allergy sufferer, so he's not like on constant antihistamines. He just probably has low aqueous. His work environment has just sort of got for him, maybe even his contact lens wear. So treatment option for him, we start with basics. We use a lot of Manuka honey and expression in rooms expression and home sort of therapy as well, home compresses. So we're going to start with his meibomian gland dysfunction. He's got meibomian glands, they're just blocked, so we'll unblock those, but we'll watch his aqueous as well. So what else can you do? Well, literally everything. The testing parameters on the Pro is, it's not endless, but it's pretty good. And as I said to you, the more you utilise this and the more you use it, the more applications you see and the more you actually want to look at. And those patients who are really problematic, he's an easy one. That's why I chose him. But those problematic ones, the ones with 3 autoimmune diseases and inflammatory conditions or nothing, and they're just horrendous. The more you look, the more you'll understand the ocular surface. And as I said, all those subtleties. So the things we can add, and as I said, you can customize this as much or as little as you like. You can use the preset functions, or as I said, you customize. So you go over into your settings over here. There's a whole heap of things you can change, your order of assessments, whatever you want to do. I don't touch that. I leave it the way it is at the moment. But this is where, again, it gets exciting. Yes, you can customize the Classic, absolutely. But what you're testing in the Pro is just a lot more advanced and a lot more detailed. So for each of these testing, your screening, your individualized, I'd call mine, MGD, your follow-up, you can select whatever you want to be into those testing reports. You can also go into your recommendations, and it's not just about making your own recommendations. It's actually being able to go, okay, this is a mild case, and then having your default settings of what your mild is. So these are my recommendations I always give to my mild. These are recommendations I give to my severe dry eye patients. So it makes it incredibly customized to the patient. And so the value that you're giving is phenomenal. And it's not just a value to the patient, it's their loyalty to you as a practitioner. You're giving them not pieces of paper, which I do at the moment. I'll give them information booklets, and sort of have this. You're giving them their customised recommendation for them, and that is very, very, very much appreciated, and it's used. So there's, as I said, the JENVIS Pro is just so much more versatile. So what it will do at the end of your capture, you're doing your assessment, you go through to the end, it will give us the report with the recommendations on it. So what sort of things can we add in? And again, not giving you a case study of this, but just sort of saying that next level, what other things can we add in? We can add things like the Schirmer and the osmolarity. So they actually will be graded as well over here. And the other thing is, as you're doing this isn't just for the patient, this is for you. So all this information, you don't have to record yourself on a separate, separate document. You may just upload this. If you've got, paperless, you might just upload this document, and this is your reference point with everything. So it's again a time saver. We can look at the tear film dynamic under video. We can look at the meibomian gland orifices, and we can even enlarge it and really see that detail in here. All this information that you don't see just when you look at the slit lamp. And of course, the Classic won't give you all of this information. We can look at the lid margin, so grading anterior blepharitis. We can grade collarettes and demodex. Very excited. We can grade the telangiectasia. So when you're doing treatment, if you're doing IPL, if you're using doxycycline, you've got a reference point, you've got a baseline for whether that telangiectasia is going down or not. Your blink function, the frequency that they're blinking. You can even do neovascularization. So again, bringing this back to, this isn't just dry eye software. This is contact lens applications. So your contact lens wearers, hypoxic contact lens wearers, which still exist. I see them too. You can look at the neovascularization and monitor that. So what it will do, as I said, give us all these sort of subheadings. We can then talk about the meibomian secretion, so you can add that in manually. And things like your inflammatory MMP9 are there. So all of this gets into your report that you can give to the patient, and you can keep, of course, for your references and comparison. When you finish it, it will give us this great the colour bar graph on here. You just finish it basically off. It'll give this report. So this is what's generated from the patient with all your recommendations on there. As I said, this is just more of a visual, I think, more than anything for the patient, but it will show them where they are on the scale of normal, yellow being normal and green being over and red being less. So that, and it'll give them an explanation. Now, a lot of our patients won't know or care about that, but a lot of them do. The other thing, of course, with their consent, you can send this to other practitioners. So they're to a rheumatologist, to their dermatologist, to their GP, if they're under the care of an ophthalmologist. Some of us are going to care about this information and some of us not, but what it does is co-share the patient's information. So incredibly valuable too. And to send it to the patient, you simply go into the email, it's already there, put in their email address and send. So it's very, very efficient and very, very simple. Just very quickly in finishing off, bearing with me, is the screening mode. Now the screening mode, again, putting this into general practice, is again a very, very useful tool. So your patients who have dry eye, who are asymptomatic and you want to watch them, they might be contact lens wearers, you might be picking up their severe dry eye that they're not symptomatic with, you can just put them onto the JENVIS, the screening, the JENVIS Pro screening. It's just got simply the tear meniscus height, nick bark redness, and your OSDI, and that will give us a baseline. You can give that to the patient, they go away, they're still not doing anything, but in a year's time or 5 years' time, when they're symptomatic, they've got that piece of paper, they've got that report, piece of paper or email, whatever, however we want to sort of share it, but they've got that information, they've got it from your practice, so they are very likely going to come back in to see you because you picked it up in the first place. So that's a fabulous tool of being able to show people what might be happening, keep them part of your practice, of course, as well. So kind of summing up now, why do I think the JENVIS Pro is worth it? Why would you buy an electric scooter when you can have a car? It does the same thing. It gets you from A to B, but it gets it faster, it gets it more efficient, you can carry more, and you can ride share. So you can do all of that collective assessment that you want to do and all that collective test, and you see it all in the one place. I'm not going to go through this because it's what I've just been talking about, but it's that summary, and I'll just leave it on there in case anyone wants screenshot it or look at it later. This is why I think the JENVIS Pro is worth it. So thank you very much for listening to my talk, and any questions?
Thank you very much, Jennifer. This was a really comprehensive and a very interesting talk. We do indeed have questions. So the first one that we've been asked is, do you do assessment on contact lens wearers when they come in with their contact lenses into your practice? Or do they have to leave their contact lenses out for the day of the appointment? And would you say the contact lens wear significantly affect your assessment if it does?
Very good question. It's a similar question to wearing makeup. Some patients obviously can't leave their lenses out. They're keratoconus as they need to. I think if we're suspecting that the contact lens wear, and this is where your history becomes very important, if you think the contact lens wear is a significant part of their dry eye, I think getting them to take it out just before their testing is very, very valuable. It's always that, what do you do? Yes, I would normally ask patients to take it out before the testing. If they're intermittent wear, get them to leave it out. So that's just, again, my personal preference. But I think you're going to get a lot more information about what they're doing with their contact. And the other thing, of course, you can do say their tear breakup time, do a couple of those parameters, Nick, but also do it before when they just take their contact lenses out, get them through their test, maybe do it afterwards as well, maybe wait 10 minutes and then repeat it and see if there's any difference to it as well. So that would also help maybe just to work out those patients who the contact lenses act as a bandage lens too.
Great, thank you. We have a couple of more questions. So one is, do you find osmolarity testing a valuable part of your dry eye workup?
I absolutely do. What I find, and this is why I don't do it as a routine at the moment, although that may change, I find it more useful when I'm doing more of a full extensive dry eye workup and I'm throwing a few other things in there, like the Sherma. The Sherma, and this is just my practice, isn't my go-to on every single patient, but there certainly is on my more advanced one. So the osmolarity becomes a really key indicator to support what is actually happening on the ocular surface with reflex tearing or low tear meniscus height. So I do utilise it, but not in my little MGB one, which is probably the most common one to do.
Okay, and then another question is regarding the patient's lifestyle. This person says he believes the patient's lifestyle greatly influence the analysis of the tear film. For example, the tablet or PC work. Is it possible, would you recommend to evaluate the tear film at 2 different times and suggest a different style?
Absolutely. So I gather what you're sort of saying there is, test it and then maybe get them to sit in the waiting room, maybe do something, look at their phone, 10, 15 minutes. It's probably not a lot, but do it at a different time. That would be really a valuable thing to do. I don't. We're a little bit busy to do that. And I guess my main focus is really getting that meibomian gland functioning happening. Because a lot of things settle down. So absolutely you could. I just don't utilise that myself.
Then also regarding doing a complete JENVIS workup assessment, what is the average chair time spent on doing this a complete workup in a busy clinic? It's obviously time is a challenge. Do you suggest a full scan for a first visit and then do customize, or what would your approach be?
Yeah, as I said, I've got kind of 2 breakdowns. A full a full test, like a full customized test, takes about half an hour. So it's a pretty heavy going on a patient, which is why we don't do it as a go-to. They're my complex patients, the ones I can't kind of work out, and I'm just not sure what's going on, which is the influence, all those other things. So I'll do it, but that is quite time consuming. And that's why being able to customize what you want from the patients, and maybe having like my MGD one, then a partial full workup, if that makes sense, because it is quite exhausting on patients. And when they're sore, sometimes you just can't do this. You know, you do those patients who just cannot do any testing for more than 5 minutes because they're just so sore. Yeah, you do need to work out how it fits in your practice. Our practice is designed around obviously just doing dry eye and now having a technician to do it. So they come in before. So sometimes people can have testing on the day. I would love everyone to have testing on the day because it's just easier, but it's just not possible for a number of different reasons. So, you know, a lot of people will come back when they come back in 2 weeks' time for their review, and we'll do the testing then. So we'll schedule that, you know, 10 minutes, 20 minutes, half an hour ahead of time for me, and then they'll come in and see me. But that's the way that we've modelled our clinic. You'd have to model it your own way, and that's why customising is perfect, because you work out what you want to do and how long you actually need to be spending doing it.
Oh, I've muted myself.
Oh, don't do that to me. I did so well.
What initial Nickput measurement would be considered abnormal? So I guess the timing is questioned here.
Yeah, I guess you're looking at your normal, your normal scale. So your normal, 12, 15 seconds or so is a fairly, like your tear breakup time is fairly normal. Under 10 is, abnormal. This is where you want to, I can talk about this for hours. This is where you want to sort of look at all these other parameters as well, and sort of see whether it measures up to your fluorescein staining or not. The other thing is, quite often you'll find, I'll say this to my technician, you'll often find that they'll keep blinking ahead of time, and if they blink too quickly, it cuts the program off, the Nickput off. They're often blinking because they can't keep their eye open. So if you can't get a measurement, that's valuable. You don't want to sit there making them hold their eyes open for 6 seconds in agony. If they just can't keep it open three seconds, their dry eye is pretty severe. So I guess, under normal is, beg your pardon, under 10 is abnormal. Over 10 is kind of normal.
Then we have a question coming in about the auto measure of the tear-meniscite. So I just want to rectify that the tear-meniscite measurement is not an automatic measurement. It's a manual measurement by the user. But you can measure it at different parts in the bottom layer. Maybe if you elaborate, do you always measure on different parts, or most of the time just the central measurement? What is your approach?
Yeah, so central measurement, and then sort of, those sort of peripheries that sort of probably...
Sorry, Jennifer, if you can just maybe come closer to, there's a little bit of a break. Yeah.
Yeah, so certainly central, and a little bit that sort of, maybe 8 o'clock, kind of 4 o'clock position on the eye. So we want to sort of maybe do 3. Sometimes I'll just 1 because it'll be the same way through. And you're right, I'm sorry, I wasn't clear. What I meant was the grading. Once you've measured it, it will then automatically grade it, but you do have to measure it first, yes.
Fantastic. So we have 2 more questions, and I think then because we've got a lot that has come in, so thank you for all of you who's actively taking part. The one question is, could you explain lipid layer analysis? Basically what I observe is the video. How do we quantify it? Because it's, again, not an automatic quantification.
No, and I don't believe we can quantify it, can we, Kai? You'd probably be able to help me on this one. It's more of a qualitative, I guess, measurement more than a quantitative, because we can't measure the lipid layer thickness. We're only observing that colouring, if you like. The different colours is going to give us that different lipid composition. Is that correct, Kai?
Absolutely correct.
Yeah. We'll wait for that for OCULUS to make that development. Yeah, so it is an observation, and it is hard because if they don't have any any lipid, you can't see anything. So, but that tells you if you can't see colour on that lipid analysis, they haven't got lipid, and you'll know that because when you're doing meibomian expression, nothing's coming out.
Exactly. I feel it's almost like working with a slit lamp. You need to get, like you say, the more you use the machine, the more experienced you become, the more you see the colors in the pattern of the lipid layer, etc.
Yeah.
A last question for you, and the very last I will address to Kai, is does the amount of fluorescein you instill affect your results? I.e., do you need to make it uniform or measure how much you instill, or the time or the time from installation to measurement?
Yeah, absolutely. I have my own little technique that I do. I saturate it, I wait probably 2 seconds, flick it off. And again, this is what I teach my technician to do, put it in straight away. And so when I'm doing the videography, so your blink reflexes, obvious, your tear breakup time, I'm just saying straight onto that. You've got to be really quick because otherwise the fluorescein does, it does sort of wear out pretty quickly. If I was doing research, when I do research, I'll actually use more of a pipette and something like 2% fluorescein, and I'll actually have it as a measurement. So I've got that qualitative, with the response. But realistically, you just want lots of fluorescein on there. So I have my little technique where I use fluorescein strips, put it into the, the inferior conjunctiva, the fornix, and start videoing straight away.
That's right. Yes.
Yeah.
Sorry. Yeah.
Sorry, Kai. Yeah.
I wanted simply to add at first, thank you very much, Jennifer. I just want to add technically wise. So if we use for imaging, the imaging mode for assessing fluorescein patterns, we have the ability to adjust the image settings, like checking the volt and the parameters, so that we have ideally the best illumination in according to the applied fluorescein dye, so that we can adjust and see that we have no extreme green or extreme blue area, so that we better can assess where we can see the findings of staining and so on. So yeah.
Great. Kai, while I have you on as well, can you, for the last question, we've got which of the parameters are automatically graded? Can you give us a quick overview on that?
Yes, I can. So the automatically graded parameters are like the redness scan. So we have a number of a value over there. We have as well as the NICBOT parameter. So we get the number, the classification, which parameter is automatically done. And all the other one, which we can see like meibomian glands, like we have the lipid layer. These are semi-graded ones, so that we get a first initial start in the grading process, but you have the ability to adjust by your own. So that's the process we are currently doing.
Thank you. So with that, I think that's the end of our question session. Again, thank you for being actively part. This is great to see so many questions coming in. Jennifer, thank you for an absolute fantastic lesson. I learned a lot and I enjoyed listening to you. We appreciate you taking time out of your evening to present to us. And from Oculus side, thank you to each and everyone. And we wish you, before I say goodbye, this is recorded and will be soon available on the Oculus YouTube channel. So with that, I will wish you a good night for those of you down under. The rest of you, have a good afternoon. And for us on this side, have a good day. Thank you and bye-bye.